Good afternoon, everyone. My name is John Gallo. I'm the Chief Executive Officer and Executive Director of Legal Aid Chicago. Welcome to our 7th session of our webinar series on the emerging legal crisis facing Chicago's Black and Brown communities. Our session today is going to focus on health inequities. Today, Kirkland & Ellis is hosting our webinar. Kirkland is one of our longtime law firm partners, and we're pleased today to be joined by two of Kirkland's equity partners. First, Nader Boulos. Nader has been a longtime board member of ours and serves now as one of our co-chairs and is part in Kirkland's office here in Chicago. And second, Lisa Madigan, who not too long ago just became a partner at Kirkland. As all of you know, Lisa was the Attorney General for the state of Illinois from 2003 to 2019 and did a fantastic job in that role, and in that role worked with us as a partner in many important subject areas, including foreclosure and consumer issues during the last crisis. She is also our Champion for Justice Award winner this year. So I'm going to turn over the hosts, Nader and Lisa.
Thanks very much, John. On behalf of Kirkland & Ellis, it's my privilege to welcome everyone to today's installment of the emerging legal crisis facing Chicago's Black and Brown communities. As John said, Kirkland is a proud supporter of Legal Aid Chicago and its mission to advocate for the most vulnerable members of our communities to make equal justice under the law a reality and not just an ideal. At a time when I think all of us have been trying to come to grips with the scale of the structural problems that we have in our society and the magnitude of the impact that they have within our communities, this series of presentations has really brought home the powerful impact that free legal aid has in the fight against inequality. Also, the incredible range of fronts on which that fight is waged, and in short, the fact that Legal Aid Chicago's mission has really never been more vital than it is today. So I want to thank you first, all of you, for joining us and being part of that effort. I want to thank everyone joining us today for the many ways in which I know you and your organizations support Legal Aid Chicago. Thank you as well to my colleagues at Kirkland & Ellis, many of whom I know are on today's presentation, and over 300 of whom have stood shoulder to shoulder with Legal Aid Chicago working on the organization's matters. And most importantly, I want to thank the incredibly talented and exceptionally dedicated team at Legal Aid in Chicago, attorneys and staff, top to bottom, for all the work that you do. All of us are proud to stand with you in this fight. With that, I'm happy to introduce my partner, Lisa Madigan, who will tell you more about today's presentation.
Thank you, Nader. So good afternoon to everybody. I am very pleased to be with you today about this incredibly important issue. I think, as we all unfortunately know, for many, many years, forever, healthcare and access to healthcare has been insufficient for Black and Brown people throughout our country. And certainly with COVID-19, that inequality come to the forefront. And so I want to thank Legal Aid Chicago for focusing on this very important issue today and for bringing together some incredible experts to have that discussion with all of us. And so let me introduce the panelists who will be speaking with you this afternoon. First, we have from Cook County Health, Leticia Reyes-Nash, who is the Director of Programmatic Services and Innovation, as well as the co-lead for the Center for Health Equity and Innovation, as well as Bobby Marie Pollard, who is a medical social worker at Stroger Hospital. And then the experts from Legal Aid Chicago are Caitlin Quigley, who is a supervisory attorney with the Public Benefits Practice Group, as well as Gwen Kaiser-Machan, who is also a supervisory attorney with the Public Benefits Practice Group.
Well, thank you so much for the opportunity to be part of this important webinar series. I'm excited to have the opportunity to present today. I'm a firm believer that we need to work across systems with partners to create new ways to advance health equity in our communities. I believe forums like this can help spur unique, innovative partnerships to advance health equity. Today, I plan to give you a brief overview of health equity and share a bit about what we're working on here at Cook County. So let's start with some definitions. I think that's always a good place to start as we're talking about this work. This slide shares an example of how health equity, health inequities, and structural racism can be defined. The most important note I want to make is that in order to achieve health equity, which is optimal health for all people, it's important to acknowledge that structural racism is in fact a driver and an enduring supporting framework for health inequities. This is important to acknowledge because the dismantling of this structure is a critical strategy to be able to effectively advance health equity. Next slide. Now, this is the Barheim model that helps to show kind of the ways that public health intervenes and creates interventions to achieve optimal health. And for those of you who don't know, you are all part of the public health system. And for those of us in public health, we often say everything is public health. And I think actually COVID-19 has illuminated that in a way that really is important in understanding the interconnectedness of all of the different systems. And if one of those systems fail, then it impacts other systems. And so it's really important to note that. This model shows how we can think about developing strategies to advance health equity. As you can see, the downstream areas on this model focus on individual interventions that focus on the results that are really dealing with the results of the upstream impacts. This is where healthcare really focuses the most of their efforts and most of their resources. And we know that those resources and efforts that are invested on those downstream actually have the least impact on outcomes. The upstream areas, which include social inequities, institutional inequities, and living conditions, have the most impact on whether someone will have an opportunity to have optimal health. I would encourage you to actually think of this model and actually flip it on its side and think of it as vertical rather than horizontal. As we think about advancing health equity, we should be layering interventions. Think about how we address social, institutional, and living conditions while we're thinking about individual interventions. Next slide. Structural racism has been at work through racist policies like redlining, limited access to health insurance and health care, community disinvestment, and the criminal justice system, which disproportionately incarcerates people of color. These maps just demonstrate the long-standing impact of policies like redlining, shown on the left. And then if you look at that mapping of the poverty index and the low child opportunity index on the right, there is no argument that there's a linkage and long enduring impact of these racist policies over time. Next slide. So how do we advance health equity? This graphic or similar graphics are often utilized to provide a visual of what we mean by equity. I will note that none of these visuals are perfect, and there are lots of different ways that this can be presented. I'll use this visual for purposes to help make a distinction between equality and equity. When developing equity strategies, it's critical to take into account the various structural barriers that exist and understand that there are different needs. Another way that this is often depicted is to show how privilege moves people in the front of the line in a race, and that structural barriers can push a person to a much different starting line. Liberation, that's listed in the third box, which suggests self-determination without structural barriers. To move towards equity or liberation, a more holistic approach to strategies is critical. Next slide. So what is CCH doing, Cook County Health doing to advance health equity? Cook County Health has been serving the people of Cook County for over 180 years, regardless of the person's ability to pay. We have provided services. That's the core mission of our organization, and we have been creating healthcare access for those who do not have care. This is important and critical, but Cook County Health is continuing to grow its work to address the needs of communities that we serve across Cook County. We have identified the Institute of Healthcare Improvements approach, which is on this slide, as a critical framework for how we continue to move forward. As you can see on the slide, there are 5 ways a health system should deploy work around advancing health equity. The number 1 is to make it a strategic priority, and in fact, Cook County Health has done that for the past 5 years, and it's been a key area of our strategic plan. In addition, we have advocacy as a key tenet of our strategic plan as well. These strategic priorities for CCH help us move also, that having health equity as a strategic priority for the health system has moved us towards achieving those other areas, which I'll describe in the next slide. So number 2, which is listed on this slide, you can go to the next slide. The next slide talks about, to address number 2 on the other slide, it talks about developing a process and a structure to support health equity work. In November 2019, Cook County Health created the Center for Health Equity and Innovation. This brought together my unit, the Funding and Ideation Unit of Cook County Health, together with the Data and Analytics Research Unit. We sought to create a platform for innovation at Cook County Health that focused on achieving health equity. And really, it's about moving our business into understanding how we have to address other social determinants in order to achieve equity. As you can see, these 4 circles, we believe that bringing in enduring processes for equity and justice promotion and community engagement are critical elements for us to develop projects that will create long-term sustainable change. Next slide. In this center, we work on several areas, such as food insecurity, working to address the needs of the justice involved, housing insecurity, behavioral health, maternal child health, and much more. Today, I'll provide 2 examples of programs that we're working on to illuminate how we approach addressing these issues. As all of you, I'm sure, are aware that opioid use disorder is a significant issue in Cook County, and there's a clear disparate impact of opioid use disorder. Not only are more African Americans impacted by the opioid epidemic in Cook County, there's a larger number of African Americans who are charged with drug offenses in Cook County. So to address this disparity, Cook County Health has a number of programs and projects working to increase the engagement of individuals into treatment and care, with not only the goal of successful treatment, but also to work and reduce the engagement with the justice system. One example I can provide about this work is our work with adult probation. Cook County, in partnership with adult probation, is working to do a screening and referral for treatment process. In addition to designing the intervention for the individuals, Cook County Health clinicians have provided clinical guidance to adult probation regarding policies that govern drug testing and penalties for those who fall out of recovery. It is insufficient to simply deploy a clinical intervention without thinking about the policy and systems that prohibit successful engagement. Next slide. Another example of the work that CCH is doing is to address housing security and homelessness in Cook County. Cook County Health has actually a very long history of working on addressing the needs of those who are experiencing homelessness in Cook County. In fact, they were one of the first to actually create a study to demonstrate the cost value of engaging individuals with high medical needs into housing. Over the last 3 years, we've been really strengthening our partnerships to help identify more resources to effectively link individuals to housing resources. Cook County Health did a cross-data match with the Homeless Management Information System in the City of Chicago and with suburban Cook County. And in that data match, we found that Cook County Health serves 83% of people experiencing homelessness in the City of Chicago and 36% of those who are experiencing homelessness in suburban Cook County. Although we think that 36% is actually a little low, but we're continuing to look at the data. Cook County partnered with the City of Chicago and other partners to participate in a collective impact program called the Flexible Housing Spending Pool. This pool creates new funding to support permanent supportive housing resources for individuals who are high system users of the health system and the homeless system. Really, again, working to create new pathways for interventions and engagement to address these issues. Next slide. So what is the foundation for our sustained success? For us here at Cook County Health, the number one thing we need to continue to work on and develop further is having community voice in all of the work that we're doing, and really start to build a community co-design process, which you can see in this graphic shows as a foundation of all of the work that we need to do to address health equity. So here at Cook County Health, we're continue to be committed to doing this work, but I just want to note we can't do it without partnership, without innovation, without looking at solutions in new ways and have new partnerships to do this work. So thank you. Now I'm going to introduce Caitlin Quigley, who's the supervising attorney at the Public Benefits Practice Group at Legal Aid Chicago, and she's a great partner of the health system, so I'm happy to be here today with her and turn it over to her.
Thanks, Letitia. Letitia explained to all of you what health equity is. I'm going to take a moment to highlight some inequities that are particularly relevant in these times and explain some of the history of how we got here. There are many examples of how Black and Brown people experience unequal health outcomes. Here are some glaring statistics. The Chicago Department of Public Health just issued Healthy Chicago 2025, Closing Our Life Expectancy Gap. The report notes that on average, a white Chicagoan lives 8.8 years longer than a Black Chicagoan. It is estimated that the disproportionate impact of chronic diseases accounts for 4.3 years. Gun-related homicide accounts for 2.1 years. Infant mortality accounts for 0.7 years, HIV accounts for 0.5 years, and opioid overdose accounts for 0.4 years. These kinds of trends have continued when it comes to COVID-19. While 30.4 per 100,000 white Americans have died from COVID, 88.4 out of 100,000 Black Americans have died, a rate almost 3 times as high. Indigenous Americans, Pacific Islander Americans, and Latinx Americans are also seeing much higher COVID death rates than white Americans. In August 2020, the Centers for Disease Control issued a report finding that Hispanic children were 8 times more likely and Black children were 5 times more likely to be hospitalized for COVID than white children. 75% of children dying from COVID are Black, Brown, and Native American children, even though they represent only 41% of the country's population. The CDC recently identified the following factors that contribute to increased COVID risk: discrimination, healthcare access and utilization, occupation, gaps in education, income, and wealth, and housing. These are the social determinants of health that Letitia described for you. The CDC report also noted that some people from racial and ethnic minority groups may hesitate to seek care because they distrust the government and healthcare systems responsible for inequities in treatment and historical events. America's history of abusive healthcare practices to Black and Brown people has created a legacy of mistrust. J. Marion Sims is known as the father of modern gynecology. In the mid-19th century, he contributed revolutionary tools and techniques to the medical field, like the modern-day speculum and the Sims position. But his breakthroughs emerged from experiments on enslaved Black women without the use of anesthesia. There are also multiple examples of minority women being sterilized without their consent. In the mid-1970s, the Indian Health Service sterilized over 3,400 American Indian women without their permission. Between 1920 and 1945, eugenic sterilization laws were disproportionately applied to Latina women and girls. Almost 20,000 Californians were sterilized during this time without their consent, and Latinas were 59% more likely to be forced to undergo the procedure. In 1932, the Public Health Service initiated the Tuskegee study of untreated syphilis in the Negro male. 600 Black men were misled and not given all the facts required to provide informed consent. The men were never given adequate treatment for the disease. Even when penicillin became the drug of choice for syphilis in 1947, researchers did not offer it to the subjects. This is Dr. Cornelius Dusty Rhodes, who served as the first medical director of the Sloan Kettering Institute. In the 1930s, he was sent to Puerto Rico by the Rockefeller Foundation to help study and treat anemia. While in Puerto Rico, Dr. Rhodes wrote a letter to friends back home that stated he had intentionally injected cancer cells into his patients, and he referred to his patients as experimental animals. He described Puerto Ricans as the dirtiest, laziest, most degenerate and thievish race of men, and stated the matter of consideration for the patient's welfare plays no role here. In fact, physicians take delight in the abuse and torture of their unfortunate subjects. And this isn't just history. Black Americans and people of color have reason to mistrust the system today. A George Mason University study issued in August of this year found that Black newborn babies in the United States are more likely to survive childbirth if they are cared for by Black doctors. They are 3 times more likely than white babies to die when they are looked after by white doctors. For all of these reasons, Black and brown people have reason not to trust the healthcare system. Unequal treatment by healthcare providers, unequal health outcomes, unequal social context driving all of this. This is really heavy stuff, and you might be wondering, what can a lawyer do to help with all of these issues? Why is Legal Aid Chicago even involved in this presentation on healthcare? We are going to tell you about Legal Aid Chicago's medical legal partnerships. When discussing health equity strategies, Letitia mentioned that health systems deploy specific strategies and develop community partnerships to improve health equity. Medical legal partnerships are one of those tools. Healthcare providers choose to partner with lawyers in order to offer care beyond medications, vaccinations, surgeries, and other clinical services that we often think of as healthcare. When healthcare providers engage and invest in medical legal partnerships, they demonstrate their intention to provide medical services that truly address their patients' needs and improve overall health. They embed lawyers on their healthcare teams to help address some of the social determinants of health. The lawyers train the medical teams to identify which social problems have legal solutions. Medical providers are then able to refer patients for legal assistance, and lawyers follow up with the medical team during and after the legal intervention. Medical legal partnerships work. They have been studied, and the studies show that they help improve health. Studies on MLPs have found that with medical legal partnerships, people with chronic illnesses are admitted to the hospital less frequently. They specifically studied asthma and sickle cell anemia and found that patients with those conditions who received care in medical legal partnerships were admitted less frequently. Also, people more commonly take their medications as described, and people report less stress and experience improvements in their mental health when they receive services from MLPs. MLPs also have impact beyond individual patients. Medical legal partnership teams often next slide, please. Medical legal partnership teams often detect patterns in patients' needs that reveal opportunities to advance policy solutions for whole communities. For example, the Health Justice Project with Erie Family Health Center was seeing patients who had lead poisoning, where the families had housing vouchers, which helped them afford their rent. When their kids had lead poisoning, the families wanted to move to safer homes, but they couldn't move and also keep their housing assistance. The MLP built a multi-state coalition that got the U.S. Department of Housing and Urban Development to update its federal lead regulations, and also worked to pass a federal bill that would require lead inspections of all federally assisted housing units before the families move in. So as you all know, there are many, many types of legal problems, and MLPs focus on what we call health-harming legal needs. I'm going to walk you through some social determinants of health, the legal interventions that target these areas, and how the legal intervention can help improve health. The first area is income. Lawyers help by appealing denials of food stamps, health insurance, cash benefits, and disability benefits. This improves health in a variety of ways. With access to health insurance, the impact is pretty clear. It helps pay for medical appointments and medications. When we're looking at access to SNAP benefits, we can look at the choice between what we call heat and eat. Are people going to buy food each month, or are they going to be able to pay their rent and their utilities? And when people have access to healthy food, they can help them manage chronic diseases and help children grow and develop healthfully. The next area we look at is housing and utilities. Legal services can help by securing housing subsidies, improving substandard living conditions, preventing evictions, protecting against utility shutoffs. A classic example that people talk about in MLPs is when a child is going to a doctor for asthma and it's not getting better even though the child is taking their medication. And then the doctor finds out that there's mold in the apartment, that the child is breathing all the time. And unless the child is in a different environment, we know their asthma isn't going to get better. So lawyers can help address the conditions issue in the apartment. You can also imagine a patient without electricity. What if they need to refrigerate their medication, or what if they need to use a CPAP at night? Next slide, please. The next area we look at is education and employment. Research shows, So lawyers can help by helping secure specialized education services, preventing and remedying employment discrimination, and enforcing workplace rights. Research shows that a quality education is the single greatest predictor of a person's adult health. So consistent employment means consistent income, and it also can mean consistent access to healthcare, as we've particularly seen as a problem in this pandemic. Access to health insurance is often linked to access to employment. The next area is legal status. Lawyers help by resolving veteran discharge issues, clearing criminal records, and helping clients obtain documented immigration status. Clearing a person's criminal history or obtaining documented immigration status can help a person access employment and housing, and that can improve their health in the ways that we just talked about. The last area that we focus on is personal and family stability. Lawyers can help with getting restraining orders and other family law remedies when there's domestic violence, and can also help with securing adoption, custody, and guardianship for children and adults. The link to health for domestic violence is pretty direct. Safety from the physical and mental effects of domestic violence has an immediate impact on health. We also see a lot of questions and do a lot of work about guardianships, looking for having established relationships in place for children with severe disabilities when they turn 18, and for older adults if they have dementia or other health conditions that affect their ability to care for themselves. Having the legal documents in place that allow others to help make decisions or help care for them when they're not able to do so by themselves. So Legal Aid Chicago currently has 2 MLPs operating to address these health-harming legal needs. The first is the Health Justice Project, which is a partnership between Erie Family Health Center, Loyola University's Law School, and Legal Aid Chicago. It was founded by Erie and Loyola, and Legal Aid Chicago joined in 2015. Erie is a federally qualified health center that provides medical, dental, and behavioral health services to patients regardless of their ability to pay. According to Erie, 71% of their patients are Hispanic, 40% of them are best served in Spanish, 62% of them are female, and 47% are 19 years old or younger. Over 90% of Erie patients live in low-income households. Erie has 7 large primary care centers and 5 school-based health centers in Chicago, and providers at each of these locations make referrals to Legal Aid Chicago through the Health Justice Project. The other MLP we would like to highlight for you today is Health Forward Salud Adelante, which is our partnership with Cook County Health. The MLP has been accepting referrals for about 3.5 years. As Letitia mentioned, Cook County Health provides healthcare to residents of Cook County regardless of their ability to pay. They operate Stroger Hospital, which is a level 1 trauma center, Provident Hospital, which serves the city's south side, community health clinics throughout the county, and County Care, which is a Medicaid managed care organization. In 2018, Cook County Health reported that it served over 200,000 unique patients. 51% of CCH patients were African American and 32% were Hispanic or of Latino origin. In many medical legal partnerships, the referrals come from clinicians, the doctors and staff providing healthcare directly to patients. Our Health Forward MLP is different because referrals come from care coordinators. They are nurses, social workers, community health workers who work with patients in hospitals and members of County Care. They help them access the care that they need and link patients to other resources to improve their health. And in our Health Forward MLP, they're the ones who make the referrals to Legal Aid Chicago. So just like our healthcare partners, both the Health Justice Project and Health Board Salud Adelante serve Black and brown people. Here are a few statistics. In 2020, we've received about 750 referrals so far. 25% of those referrals were for clients who speak Spanish. We only collect information about race when we complete an intake interview with a client who's referred, and unfortunately, we don't reach all clients referred to us. But when we have asked clients to identify their race, 39% have identified as African American and 44% have identified as Hispanic. So what do we do for these folks who are referred to our medical legal partnerships? Here are a few examples of recent MLP cases. So a care coordinator from Schroeder Hospital referred a patient to Health Forward back in 2017. At that time, he was living on the street, he had untreated serious mental illness, and he had no source of income. Health Forward staff at Legal Aid Chicago represented him in an application for Social Security disability benefits. He got denied and had to appeal, and he had a hearing with a judge in May of 2020. Social Security eventually approved him for ongoing SSI benefits, as well as almost $23,000 in back benefits. With this reliable source of income, he qualified for subsidized housing, and he was able to move into his new apartment in June 2020. As another example, in late 2019, a care coordinator from the complex care team referred a county care member to Health Forward for help with her SNAP. Legal Aid Chicago looked at her situation and determined that the Department of Human Services had incorrectly charged her with a SNAP overpayment, was giving her less SNAP each month than she and her 2 kids were entitled to, and sent her a notice that they were going to terminate her Medicaid coverage, which wasn't proper. Legal Aid Chicago filed an appeal with the Department of Human Services, negotiated resolution of the overpayment, and secured the family's Medicaid and an additional $150 per month in SNAP benefits. The last example I want to share with you is from earlier this year. A care coordinator from the waiver team referred a county care member to Health Forward because she had a notice of eviction. She was 62, disabled, and living in subsidized housing. Health Forward staff determined that her landlord had decided not to participate anymore in the subsidy program that she had. And they also determined that she was eligible for SNAP and cash benefits that she was not receiving. Legal Aid Chicago attorneys helped her apply for those benefits and advocated with her landlord to give her additional time to find appropriate new housing for her. And she is now stably housed and receiving an additional $180 per month in SNAP and cash benefits. And thank you for listening to a little about Legal Aid Chicago's MLPs. I'm now going to turn it over to Bobby Pollard. She's a care coordinator at Schroeder Hospital, and she's been working on the front lines of the COVID pandemic.
Thank you, Caitlin. Hi, my name's Bobby. I'm a medical social worker here at Schroeder Hospital. I cover 3 ICU units here at the hospital, and all 3 have ventilator capacity. At the peak of the pandemic, all 3 were full with COVID positive patients, most of whom were intubated and on ventilators. So I'm going to talk a little bit today about my role as a social worker during the pandemic, the resources that our patients and our families needed, and also a snapshot of our patient and some of the barriers to access those resources. So first, I should say, prior to COVID, the bulk of my work focused on discussions with both the patients and the families. Usually these were in relation to discharge planning or goals of care. But when COVID hit, my role shifted a bit because most of my patients, as I mentioned, were intubated and they weren't able to speak for themselves. So a lot of my work was primarily only with the families. I want to say here that my comments are anecdotal. They are my personal observations working on the ICU. They're not from any data or analysis, and they do not necessarily represent Schroeder Hospital as a whole. I do also flip back and forth between past tense and present tense. I think it's because I'm thinking about May, June, and July, some of the more difficult months. So forgive me for that grammatical shift. So my role as a social worker. So the conversation looked like, first and foremost, being a liaison between the medical teams and the families. We had a strict no visitor policy, so the families were dependent on the care team for daily clinical updates. We coordinated FaceTime sessions if it was appropriate. And I really wanted to make sure that the communication between the doctors and the families was fluid and it was comprehensive, and that the families had the medical literacy to understand what was happening, what the recommendations were, and what we thought the next steps would probably look like. Another big role was identifying healthcare power of attorney if the patient had one. Most of our patients did not, and so then it was identifying who the surrogate decision maker would be by Illinois state law in the event that the patient was intubated. We were sometimes able to get advanced directive paperwork completed before the intubation occurred, but a lot of times we deferred to the surrogate decision makers. And I should mention that a lot of our patients have comorbidities, asthma, COPD, diabetes, obesity, but for all intents and purposes, they were living very full and functional lives. So they were working every day. We had a lot of essential workers. So they didn't have a lot of this paperwork in place. These weren't conversations that were being had because they weren't critically ill before they got COVID, a lot of them. So it's just something to keep in mind. These are people who are able-bodied, they're well, and then they get COVID, and in a couple of weeks now they're intubated and sedated and on pressors. So it can be like a very sharp, drastic turn for a lot of these families. Another important role that I had was understanding family dynamics. So did the rest of the family test positive? Do they know how to get tested? Do they have enough food in the house? So that was probably is and was my biggest request is for food. And a lot of times there wasn't enough food in the house. So it's finding creative ways to get them food, especially if the family has tested positive, because we want to keep the community safe. If someone's COVID positive, we don't want them going to the grocery store. But also, like, they have to eat. So Lakeview Pantry was a really great organization that hand delivered boxes of food for free to our families, and they delivered way outside their delivery jurisdiction. And they were excellent for families that didn't have the financial resources for food, but they were healthy to go into the community. We connected them with the Greater Chicago Food Depository and Claretian House, Claretian House had free food vouchers for them to pick up for families who are impacted by COVID. And then as far as housing went, I wanted to make sure that our families were stably housed. Were they up to date on rent? Were they having clear conversations with the landlord? Were they being evicted? Did they know what their rights were? And I think it's important to note that as the pandemic continued, the need became greater because the families had gone through their life savings. People had been let go. Multiple family members were sick. So I would say that the need for resources in the summer was greater than in April. And I would say right now the need is the greatest because so many families, they don't have anything. Let's see. Also, it was important for me to understand how the family unit was doing because most of my patients did not have insurance and they didn't qualify. They weren't eligible for insurance, which meant that if they were able to leave the hospital, they were going to go home. So taking that view of health as being holistic and that our environment impacts our healing process and our social support network is important also to our healing process. How my family unit was doing, keeping them safe and healthy, was also keeping my patients safe and healthy in the long run. Initially, when we were linking families with resources at the beginning of the pandemic, we didn't know how the virus behaved exactly. So a lot of these applications for rental assistance and financial assistance, and I have slides that have the specific referrals that we did, A lot of these applications were online, but a lot of our families didn't have access to computers or to internet, or they felt overwhelmed by the process of applying for online. So it was a whole family effort. We roped in nieces and nephews and children, adult children, to make sure that they could submit these applications correctly so they could hopefully receive some kind of assistance. I should also mention that we have some important players on the care team. We have an excellent bereavement social worker. Her name's Jacqueline, and she did and does a lot of the heavy lifting with the grief and the trauma. Also, we have a chaplain here who's wonderful, and he was really instrumental in bringing in different spiritual figureheads for families who were comforted by having a ceremony particular to their faith. Which leads me to also talk about when someone died. And we lost a lot of patients here on the ICUs. I worked with the families then to walk them through the funeral and the burial process, how to select a funeral home, cremation versus burial. And it seems like such a callous conversation to have about the cost of cremation versus burial, but the cost is prohibitive to what families want sometimes. And so it's also a very necessary conversation to have. There were a few programs that I could link families to, but there was not much available to our families. And then, as many of you recall, when the pandemic hit, it was really, really difficult to get cleaning supplies. It was difficult to find hand sanitizer. So a lot of our families didn't have these things. They didn't have a Lysol, so they didn't have a way to disinfect their home in the event that only one of their family members had tested positive, or a couple of them. They didn't have a way to disinfect, and then they also didn't have a way to engage in their community safely. They didn't have masks, and they didn't have hand sanitizers. So there's a really great grassroots effort keeping spirits up by this couple, Barb and Bill, and they mailed care packages full of these things to our families. So we're super grateful to them too. So I have a few slides. Most of our patients were Hispanic. I mentioned we had a lot of essential workers. A lot of our patients have comorbidities. And there are a few slides with specifics as to the resources that I briefly passed over. But that's it for me. I want to thank Legal Aid Chicago for the opportunity to speak about my experience and for all of their help with our patients. And now I'm going to turn it over to Gwen. Thank you.
Thank you, Bobby. Next, I'm going to talk about the ways Legal Aid Chicago and volunteers are helping families access DHS supports they need to stay healthy, safe, and secure during the COVID-19 pandemic. The financial disruption related to the pandemic resulted in millions of Americans losing health coverage. More families and children have become food insecure. 5.4 million Americans lost health coverage between February and May 2020. The unemployment rate in Chicago soared from 3.4% in February to 17.5% in April. Though things have improved, our unemployment rate is still nearly 4 times higher than it was in February. Without employment, people are struggling to keep their families safe and secure during the pandemic. Legal Aid Chicago has long had a public benefits enrollment project funded by the City of Chicago. Before the pandemic, we met all of our clients in person at City of Chicago Department of Family and Support Services offices. When we began working remotely in March, we had to develop a new way of delivering this important service. Working with the city, we created a phone hotline so that clients could connect with us during this time when many needed our help more than ever. We also realized the need for benefits like Medicaid and SNAP food assistance would skyrocket, and that the need was not limited to the City of Chicago, but also affected families living in suburban Cook County who normally are not served by our City of Chicago enrollment project. To meet this need, we launched the new BENEMAX Volunteer Project. So far, we've trained over 100 volunteers how to help clients maximize the DHS benefits that struggling Cook County residents can receive. These benefits include vital health insurance, food assistance, and cash assistance for vulnerable families. Through the hotline, we have helped 800 people through our City of Chicago Public Benefits Enrollment Project. and we connected another 400 people to volunteers. Through the volunteer project alone, we've helped low-income residents obtain over $267,000 in annual SNAP food assistance, Medicaid, and cash benefits. Here's just one example of the impact of the BENEMAX project. Ray is a 50-year-old man with disabilities living in Skokie. Even before the pandemic, Ray was struggling. Because of his poor health and his inability to hold a job because of his disabilities, Ray has been bouncing between homelessness and living in a nursing home. In the confusion at the beginning of the pandemic, his SNAP food assistance was terminated. Volunteer Adam Greedus, a partner at Seyfarth Shaw, stepped in to help Ray. Thanks to Adam, DHS reversed its decision, and Ray received his benefits plus monthly pandemic food assistance for April and every month going forward. Adam also noticed that DHS mistakenly had Ray in medical coverage for people living in a nursing home. This made it difficult for Ray to access the medical care he needed. Adam got that fixed. And he even went another step further. Adam realized that the Social Security Administration had incorrectly reduced Ray's SSI benefit by 1/3. So he successfully advocated for the Social Security Administration to reinstate Ray's benefits at the correct amount. Thanks to Adam, Ray now has access to food and income and the ability to access the medical care he needs. This is just one example of how volunteers can help struggling people in our communities during this challenging time. Now, I'll pass things over to Melissa Pachola, Director of Volunteer Services, to talk more about volunteer opportunities at Legal Aid Chicago.
Thank you, Gwen. And what an eye-opening presentation, highlighting the need for advocates such as Caitlin and you to help solve some of these complex issues that our clients are going through. And for those of you who may be interested in working alongside us, I'm going to highlight some of the ways that you can get involved in Legal Aid Chicago's work. At Legal Aid Chicago, we have over 20 different volunteer opportunities across the agency. And Gwen mentioned one of our projects, which I'll discuss more in a second. But you can see here that our opportunities run the gamut of skill levels and time commitments. Caitlin and Bobby both mentioned the importance of advanced directives documents such as healthcare powers of attorney. And we do have a volunteer project focused on preparing those documents. And many of our clients are actually referred by our medical legal partnership. But you can see that we offer a wide variety of opportunities to serve our clients and help us meet their needs. As Gwen mentioned, one of our volunteer projects focus on helping clients get and keep public benefits. This opportunity is appropriate for attorneys and non-attorneys. We offer comprehensive training, which is available for you to watch whenever you can due to the magic of the internet. And we know that many of you may not be public benefits experts, which is why we provide training and guidance to help you understand the system and your role. Clients benefit from having an advocate beside them, and I promise you, it can be you. These cases are not long-term, they are not time-intensive, and they do not require in-person advocacy. But they are crucial to helping a client get what they need. We are extremely successful at resolving these cases in favor of the client, and the client needs exceed what we can do with our own staff. So the need for volunteers is great, particularly right now. You can find more information about all of our volunteer opportunities on our website, and you're welcome to reach out to me with any questions that you may have about any of our opportunities and how you might be able to help. And so I'll turn it back over to John Gallo now.
Thanks, Melissa. Thanks to you, Letitia, Bobby, Caitlin, and Gwen for those terrific presentations. And a shout out to Elise Citrini, who I've seen in the chat. Elise, welcome back. Elise just became the executive director at the Health Law Institute at DePaul. She was one of our superstar lawyers here and now obviously has a very important role at DePaul. Many of the MLP-related things that we do here were instituted and created by Elise, so we're grateful to her, and it's good to connect with you electronically, Elise, and we miss you. So in a moment, we will start the Q&A portion of our presentation. And I think we've already had questions come in. So I think Caitlin is going to be leading the charge in the Q&A. So I'm going to pass it over to Caitlin and take it from there, Caitlin.
Thanks, John. So I think we're actually going to start with some questions for Letitia. The first is, how do you view strengthening social networks, particularly in African American communities, to motivate behaviors, enhance health literacy, etc., as tools to mitigate health disparities?
Yes, thank you. So I think that, that's a really great question. I think that it's important that we continue to work to build community voice and bring that into our programs and development. And currently at Cook County Health, we do have community advisory boards at many of our clinics that provide input. And we do have a practice in which we engage individuals who have lived experience as part of steering committee members of almost every single program that we initiate to ensure that we have that voice at the table. But what we're working on now is to actually work on developing a community co-design process where we can have something that's part of our regular business, and that we are always looking and seeking to have community voice engaged in our decision making. We are also very open to ideas and new partnerships, and we are definitely, this is an area of work that we're continuing to develop and work on, and we're open to new ideas on how we can do this in community. I will say we do have some innovative work that's happening as part of our Healthy Start grant, which is focused on utilizing some AI technology and an innovative platform called Gabby, which is a way for us to engage with moms and to have a communication and health education component to that. So that's like a new innovative tool that we're working on. We also deploy recovery coaches and people with lived experience as part of our teams of clinical engagement so that we can ensure that we have lines of engagement for our patients.
Great, and another one for you, Letitia. What metrics are used to quantify improvements in health equity?
Sure, so for each intervention that we do, we have different metrics that we're looking at, and various funders have various metrics that are attributed to the various projects, so we utilize those. Something that I think is important as we're doing this work is to really kind of push ourselves beyond what we look at as traditional measures of success and get more deeply involved in thinking about how we can engage quality of life measures. And so there's a lot of work that's been done around kind of using RCTs and other trials to kind of look at the effectiveness of a number of interventions. And one of the more recent ones that came out around the Camden Coalition was around linkage to housing for individuals who are kind of frequent users of the ER. And that was kind of controversial when it came out because it didn't show the impact that people expected. And so the question that we all can, as people who are doing this work and wanting to show these measures, we wanted to look deeper and see, did you measure everything? So understanding that simply getting a person housing and them not returning to the ER isn't sufficient at measuring. And so we have to look at what other measures are there to show the success of our interventions, and understanding that quality of life measures, being able to see your grandchild when you haven't seen your grandchild for 5 years, that's a success. And understanding how we can measure that in addition to those other metrics, I think is a critical question that we're still working on and seeking to identify.
Okay, we'll give Letitia a break. Turning to Gwen, we have the question, are there any local DHS offices open to in-person visits? And is there any outreach in person that's available for people who want to retain or obtain new benefits?
So our staff is currently not doing in-person outreach, but the DHS offices, most of the FCRC family centers are open now. However, they're very much limiting interaction for in-person services. So they're trying to target those to people who cannot do business over the phone or online. And so we're recommending that if someone can access services through the internet or by phone, that they should do them that way to avoid going to an FCRC and being turned away at the door.
And a follow-up question to that, are clients able to recertify on the phone, or are they only able to do that online?
Well, they can recertify on the phone. The phone wait times are very long though, unfortunately. And so again, if someone has internet access, we're recommending that people recertify that way. The recertification periods for food stamps right now have been extended for 6 months. So we don't know if that will be extended again in October. And we probably won't know until the beginning or middle of October if that happens.
Great, Melissa, I've got some questions I think that are best for you. Can you please confirm that there is training and that we do not need to be an attorney to volunteer? And then also, how long is the training?
Great, well, thanks. I love volunteer questions. So there is training available. The training is actually posted on YouTube, and we are happy to provide a link to anyone who's interested in watching those trainings. The training actually comes in 2 pieces. One that focuses on the application process, and one that focuses on the post-application advocacy steps. And they're each about an hour and a half long, but I promise you, they are thrilling. And they'll keep you in your seat for that time. And then absolutely, you do not need to be an attorney to handle these cases. We routinely use paralegals for this action as well as other professionals. It is not required to be an attorney, even if the case should happen to go all the way to an administrative hearing. A non-attorney is appropriate to represent a client in that setting.
All right, Letitia, if we could come back to you. We have the question. It says, I'm curious if the staggering COVID-19 statistic differences between Black and white patients are after health insurance and income status are accounted for. I guess what I'm asking is, do those inequities continue to exist after you compare 2 sets of people, one white and one people of color, who both have insurance and financial resources to access the system? Because if they do still exist after those characteristics are factored out, then that would be alarming, since that would be more proof that the healthcare system works against people of color.
Yeah, no, thank you. I think that's a great comment. I think that I can't specifically comment on the COVID data, but I can say that it is abundantly clear regarding maternal and child health data that is very much the case. And so there was lots of stuff that came out, lots of studies that came out over the last couple of years that really highlighted the fact that regardless of income, an African-American woman was treated differently in clinical settings and provided opportunities to different types of care for pregnant moms. And in fact, there are higher rates of death for African-American moms and babies in the United States and in Cook County in particular. And so that has been borne out in the data. There's lots of research that you can look at around that. And we at the health system particularly have a grant called Healthy Start, where we work on having more home visiting and other supports that we provide to moms to address that disparity. But well, we have lots of moms who have additional barriers because of various social determinants of health. This is, you can see this disparity occur across income lines, which is really a concern. And I think that as healthcare providers and healthcare systems, we are continuing to look at how to address things like implicit bias and other issues that could be contributing to a difference in care.
Thanks. Another one, if you're willing, Letitia. Are there financial incentives that can be leveraged to move other health systems or private payer insurance to address social determinants of health and health disparities?
Yeah,
this
absolutely.
is the work of the entire health sector, not just entities like CCH.
Yeah, absolutely. I mean, I think that part of what we've worked on achieving for the flexible housing spending pool was to work on getting other investors involved and not just government investors to help support additional permanent supportive housing resources within Cook County. But for the work that we're doing, we work, of course, as you know, County Care is part of Cook County Health. We are actually part of a learning collaborative with the Robert Wood Johnson Foundation to look at just this question. And so we are particularly looking at housing in our work, and we are kind of a learning ground to kind of look at how the investments in housing, in particular for County Care members, are actually creating additional value for the plan. And so we have been able to demonstrate that in many cases, but we're working further to kind of influence Medicaid policy and payment policy. So we, in that cohort of the Learning Collaborative, we have HFS as part of that, and the health system as a provider and a payer are part of that conversation, working to kind of get to that point where we can share with others how we've created a value proposition that could be extrapolated and utilized across other payers and other health systems.
I just want to point out that somebody commented to the panelists that there is a book called Cast by Isabel Wilkerson that addresses disparity in health outcomes regardless of income. They pointed out that it's chapter 24. So if anyone is interested in reading more about this and learning more about this, check out the book Cast by Isabel Wilkerson. Gwen, another question for you is, are people able to certify for SNAP and Medicaid if they have not received a recertification notice?
So usually someone can't recertify for benefits unless they've received some sort of notice from DHS. They can go into their Manage My Case account, which is the online system that DHS uses, and see if they can find a notice in there, or there might be a button where they can click to recertify.
Thank you for a fantastic effort. And thanks to all of you for joining us today. Want to make sure that you're all aware that our last webinar, I know you're disappointed to hear this, but it is our last lunch webinar, is next Wednesday, September 30th, and it's on barriers to employment. Thanks to everyone for joining us here today. Thanks to Letitia and to Bobby for joining us and providing your expertise. We're proud of our partnership with Cook County Health, and thanks everybody. Have